$15,000. All right, so definitions of falls. So things we have to kind of look out for here. So risk for falls, that means just increased susceptibility. That's derived by an accredited fall assessment tool. And we use an accredited assessment tool here at St. Joe's. And the definition of a fall is a sudden, uncontrolled, unintentional downward displacement of the body to the ground. This will include all assisted falls. One thing I like to focus on is unintentional. Healthcare workers get very nervous when a patient is on the ground, but if they got there on purpose, it is not considered a fall. If a patient gets down on their knees to vomit into the toilet, not a fall. If they mean to sit down on the ground or a stair, it is not considered a fall. Assisted falls, pretty easy. Anytime that we assist a patient to the ground, great thing about assisted falls is there's rarely injury. Fall discovery, so two different types. Unobserved falls, so we did not see them fall, but they are on the floor or they reported the fall. And then there are observed falls, so we actually saw them, or a visitor, anybody saw them fall. They can explain to us what happened that made it. So the top 10 reasons patients fall. So not in any particular order here, but fall assessment issues, fall risk assessment issues. So inconsistent rating by different staff. So one nurse scores somebody much higher or lower than the next nurse, and then no reassessment during the shift. So this is a big one. Patients change throughout the shift, and we don't always update their fall score. So if that patient's on new pain medication, new diuretics, whatever it may be, that could put them at risk when they weren't originally. Handoff communication issues, so poor communication, during shift handoff, or just, when we're giving a report to a new PST or nurse assistant, we need to make sure that we're telling them exactly what this patient's risk is and how that patient will fall. So just very important to get that information out to everybody so we know how to care for them. And then we have toileting issues. Yeah, if we fix this, we have decreased falls by 50 to 60%. But yeah, patients not asking for help when toileting, making sure we have that bed alarm on, making sure we're educating them that, hey, we need to help you to the bathroom because you are a fall risk. And then a big one is patients left alone in the bathroom. This is a tough one, especially when we're extremely busy, but the bathroom is the most dangerous place to fall. That toilet loves to break ribs, and that sink loves to give concussions. So we need to stay with them, or we need to make sure that they are safe in the bathroom. Call-out issues, so patients not knowing how to use it. Maybe it's out of reach, it's fallen down onto the floor. They just forgot to use it. Or some patients just say, I'm not using it. I'm not going to bug you. I can do this on my own. And then they fall and hurt themselves. Other things, educational and organizational culture issues. So fall prevention education is not used or consistently used. I mean, we need to educate everybody. We need to educate that patient. If they have family there, we need to educate the other nurses around, or the PST or nurse assistant. And then some team members not reacting to a fall alarm. Excuse me. So that'd be a huge culture thing. You go into hospitals that have very low fall numbers, it's because when that fall alarm goes off, you've got people looking in, nurse assistants looking in, dietaries looking in, like, hey, nurse, what's going on in here? There's an alarm going off. I've even seen some hospitals where the medical residents, the surgical residents go in there and tell the patient to be safe or to wait for the nurse or PST or nurse assistant. And then lastly on this list is medication issues. Just that when they come to the hospital, these patients are put on new medications. Maybe their doses are adjusted. So we have to be very careful that we educate them on the medication and that we change their fall risk accordingly. All right. Most important thing, especially that I think, most important thing is to personalize the care to that patient. So think, how is this patient going to fall? And then use your interventions accordingly. If you're watching this on video, then we're gonna go over this in the next video, but if this would be a live class, I would go over them right now. But so let's go ahead and wait for that video. All right, so we'll just touch on some of these things really quickly because they will also be in the video. So the Hill-Rom bed alarm, it's a really good alarm. There's 3 different settings and it's all weight-based. So the patient position is considered the first alarm. That one is very sensitive. Just that patient moving in bed a little bit will set the alarm off. Bed exiting, that's the one that we use 9 times out of 10 here. Maybe 10 times out of 10. This is the one we want you to use, and it's considered the second or the middle. If you look in the video later, you'll see that it's in the middle of these 3 when you're looking at the side rail. And this one is measuring the weight. If too much of that patient's weight goes onto the edge of the bed, it goes off. And if the weight of their legs comes off the bed, the alarm will trigger. So you can go in there and help them before they're actually getting up. And then the last alarm is the out of bed alarm, which is the too late alarm. That patient's up and already moving by the time you hear the alarm. So oftentimes you go in there and it's too late. But just so important that when we go into care for the patient, we turn the alarm off. When we're done caring for them, we turn it back on. That is huge. Turn that alarm back on. So personal alarms, we have, it's considered a chair alarm, but then on some of our other units where they don't have the Hill-Rom Advantage 2 beds that I just explained, then we have to use this also as the bed alarm. And again, I'll show you this in the video, how it works. All right, and then another personal alarm, it's this is the one that we have in the bathroom. So if we need to provide privacy for a fall risk patient, and the RN assesses the patient to be stable, so they're safe in the bathroom without us right next to them, an alarm clip can be attached to the patient gown. The RN or PST can now stand directly outside of the bathroom door, ready to enter if the alarm triggers or the patient asks for help. So big thing is we know that they're safe enough to be in there on their own. And then we just stand right outside the door. We can even have the door cracked a little bit to see, okay, are they safe? But making sure they have that alarm hooked up to them. So if they do go to get up or they start moving or they ask for help, we're right there, ready to jump in and assist them. All right, so let's go over injury prevention here. So, and this will be in the video also. So fall mats, super important. They help mitigate injury. So it absorbs, they say, up to 85% of the impact. So that's turning a broken bone into a bruise. That's turning a concussion into a headache. This is very helpful. A lot of people think that the hospital is too chaotic of a place to use fall mats, but we've used them very well, very successfully here at St. Joe's. The great thing is they're in every single room. They're right behind the door, walking into the room on a little hook, so they're easily accessible, so you can easily use them. But when we use them, we need to make sure that we create a safe exit. So if you see the little stars on the PowerPoint there, that is showing items to use. We're pretty much making it easier for the patient to exit towards the fall mat to the bathroom. So if they do fall, they're going to go on that fall mat. Make sure that the mat is put down exactly how it is in these pictures. The little handle, the yellow handle, is underneath the bed or it's underneath the chair, just so the ramped areas of the fall mat are out, so the patient doesn't trip, or so we don't trip. All right, more injury prevention. So the posy bed or the enclosure bed. This is a great thing to use for confused elderly patients that are impulsive, but it is considered a restraint. So we'll have to have all the orders in place, and we have to go through this exclusion criteria to make sure that it's safe for that patient. And if you have any questions, charge nurse or the CHS are very well versed on which patients work best in these beds. All right, we also use the BMAT on most units in the hospital. So it's the bedside mobility assessment test. So this is a great test to show us if this patient can get up, and then also what do we need to get them up safely. So it really helps with that consistency. There's a magnet right outside of the room, so when you're walking in, you know exactly what is needed if you are going to get that patient up. And then you'll learn in your preceptorship or your training of how to wrench in that BMAT flow into your flow sheets. But great tool, very helpful. Another thing that we have, this is called the Falls Tips. This is located in every single room, so we get the name on there, the date. It should be filled out every shift, and it corresponds with the Hester Davis Fall Scale. So you can pretty much use that and then check off these boxes, and then go over here to the interventions, and you can circle which ones you're using. So if you're using the walker with that patient, and we're getting them up to the bathroom and they need one assist, they need one person, bed alarm is on. So it's color coded, it's very easy to see. And another great thing is the patient is looking at this so they know what is expected of them, and also any family members, loved ones that are in the room can easily see this and understand what it entails to get this patient up. Every room is going to have the patient safety agreement. So we'll go over these 4 bullet points with all of our patients when we orient them to the room. And if they're a fall risk, then we go over all 9 items. So this is another thing. It's great to set expectations with the patient when you're going over these things. So they know what to do. They know what is expected of them. All right, let's just talk about our fall scale. The one that we use here is the Hester Davis, and these are the 8 categories that we score our patients on. And each category, if you're looking here, you can score them on more than just one of the criteria. If this patient is incontinent and has diarrhea, frequency, or urgency, we would select both of those. So instead of just, they're incontinent, they're a 3, no, they're actually a 7. And they could be an 8 or 9. So score them accordingly. And then here, once you're done scoring them, you'll see the total score. And you can see with this patient, we're going to focus on toileting, electrolyte status, and maybe behavior, medication. So quite a few. 32, that's a really high score. And also the computer automatically factors in the age for the patient. So you'll have a different score than just what all of these add up to. All right, and then, okay, what does each score mean? So 7 to 10 is low risk, 11 to 14 medium, and then 15 or greater is at high risk. But big thing is any score, any of these patients can fall. We have lots of falls in each one of these categories. It's not just that we need to focus on 15 or greater as high risk. Then, yeah, just kind of mentioning here that concentrate on the categories where the score is highest. So yeah, I'm getting this patient on toileting schedule for sure. I'm definitely going to educate them on their meds, making sure that we're keeping up with their fluid balance, and then behavior, maybe a little more education as well. Hey everybody, it's me again, Keith, the nurse education coordinator, and we're going to go ahead and go into some nursing interventions that we can use. We'll play a little game here. I'll kind of show these and kind of play along. Like, okay, do you know how this is going to help prevent that patient from falling? But the first thing I like to talk about are the fall mats. So fall mats, one of the great things is they're available. They're in every single room right behind the door. So easily accessible. If that patient needs it, let me just put it down. It takes you a couple minutes instead of having to go around and finding it. But it hangs up on a hook. When we put these mats down, we want to make sure that these handles go underneath the bed because this is the only side that isn't beveled or ramped up. But it is a trifold, so we're going to go ahead and undo it just like this, and then I'll set it on the floor. I always want to go in between the patient and the bathroom. That is most of the time where they're going to go. So it's going to be right here.
Yeah, it's beveled. So even if you're a walker that kind of shuffles or the patient shuffles, you're going to be able to shuffle right up onto it. It's a very dense foam. So if you bring your computer on wheels up onto this, you're going to be able to work with it just fine. It's not going to sink in. Now, the other thing is, if you don't want to stand on this while you're caring for the patient, which is silly because it's almost like a fatigue mat, it's very nice. You can fold up one of the sections and it pushes right underneath the bed. Just don't forget to bring it back up. All right. Now, the other things that we need to talk about when using the fall mat is that safe exit that I told you guys about. So, to make it a safe exit, yeah, put this in between the patient and the bathroom. And then over here, you want to make sure that you have bedside table right here, and then also the recliner. So if that patient's going to get up, they're going to see this and they're going to be like, oh, that's too hard to get out of. I'm going to go this way. Also, I can put up that third rail. I want to put up 4 rails for restraint, but see, makes it even harder for them to come this way. I'm going to put a picture of an X over here, anything, scary stuffed animal, just to make sure they go that way. Important thing. All right, and the last part about the fall mats are how else can you use them? So if I get the patient into the chair, go ahead and move this out, I would grab the fall mat and I would put it down right here, right in front of them. So if they get up and fall, they're going to fall on the mat. Same thing with a bedside commode, or if they're in the bathroom, I can move this mat around anywhere just to protect the patient. Okay. So again, any questions? You're going to help me. Call me, talk to your educators, talk to your leaders, make sure that you guys get the answers you need. Okay, so the next thing we're going to go into are the bed alarms. So hill round bed alarm, you're already in the PowerPoint of how well this thing works. If you look over here to the side, these are those 3 settings I was talking about. So this is the very sensitive alarm. This is the just right, or the mother bear alarm. And then this one, I'm not sure what happened there. And then this one is the too late alarm. Okay. But on those units when you don't have them, you have to go to this guy. So this is a bed alarm that you'll put down, and you'll have to hook it up to the Posey Sitter Elite. Now, so you plug it in this way, the phone jack goes right into this jack, and you set this up. It comes with an anti-slip plate or material, so it doesn't slide on the bed too much, but it also has clips to keep it in place. So it's pretty good. The only problem with this alarm is that it's not weight based like the hill round one. So it's pretty much, it's only going to go off once all the weight comes off of the mat or the pad. So the patient's already up, you better get in there really fast. When it's the weight based, you have a couple seconds to be able to come in and help the patient. All right. The other thing with this is it has to be plugged into the wall. So you'll notice this cord. This cord should be in every room. It's going to plug right into a little slot here that says nurse call. So you plug that in, plug this into that, and then if it goes off, it's not only going to audibly alarm from here, but it's going to go to your bolt phone. It's going to go to the light outside, and it's going to go to all the GRS 10s to make sure that we can come in here and help that patient. If it's not hooked up, it's just going to be an audible alarm. And if you're too far away, door might be shut. You're not going to hear them. So make sure that all 3 things are plugged in. All right, we'll go ahead and go to the chair now, because this is the other Posey alarm pad. So same thing. It's going to go in the chair. You'll have an anti-slip pad for it, and it's going to plug into the Posey Sitter Elite, and then that's going to plug into the nurse call system. Now, the problem with this alarm is that patient's sitting down. It won't go off until they are pretty much up. Now it's going to go off, but now that patient's free to do whatever they want. They're going to bebop over there, and they might fall down. So it's good for those patients that just need a reminder, like, oh yeah, I'm not supposed to get up. I hear the alarm. I'm going to sit back down. No, there aren't that many patients like that. mostly they're going to be like, I don't care what that noise is, I'm going to go do what I want to do. But there are some patients that once they hear the alarm, they sit back down. There's one in Michigan. The best thing to use if that patient doesn't listen to the alarm and they're impulsive is this guy. This is the Posey Velcro alarm belt. Now it's adjustable, so it fits around our big recliners. It fits around small chairs. But the way this guy works, I have to adjust it properly. It goes around the recliner like this. Go. And then it hooks into the Posey Elite the exact same way. And make sure it's hooked up to the nurse call system. And then when this patient sits down, put it around them like this. So now, if you think about that patient that got up and bebopped over there because he didn't care about this alarm, with this one, he's going to go to get up and it's going to hold him in the chair. And he'll be like, what is going on here? And then if he knows, he's going to undo this and then the alarm goes off. And then he's like, oh, what was that noise? So I don't really care. I'm still going to go get my cat out of the closet. And then he goes to get up. So you've bought yourself 3, 4, 5 seconds to get into the room to help. I know you're always thinking, Keith, this is a restraint. I can't use it. No, that's not the case. As long as that patient knows how to use Velcro, you're safe. So what I always do is sit the patient down, like, hey, I'm going to put this belt on you to keep you safe. Now, there's an emergency. Wall starts on fire. You have to get out of here for any reason. You just pull this little yellow loop, and then you can get up and out. And you say, hey, show me how to do that. And then if they do it, boom, it's not a restraint. If they look at you like that was magic, what you've just done, then it is considered a restraint and we can't use it. But they know how to use it. This is a great tool to give you some extra time to get into the room before that patient falls. All right, so let's go on to the little box over here with some more goodies and some more fall interventions. All right, let's see. How does a simple washcloth prevent falls? About that for a second. I know some of you know, some of you might be new. It's all about distraction. You want to distract these patients from trying to get up on their own and falling. So get a whole bunch of washcloths and towels, mess them all up, and then go into the room and say, you know, hey, Effie, could you please help us? All the people from the linen department called in, and we need these folded for the patient that's going to move next door. And she'll probably say, oh, I can help you guys out. Give them to her, give her 10, 15 minutes. She's going to fold those. It's going to keep her busy. She's not going to want to get up. She's not going to want to bother you. And then maybe she'll put on her light. Maybe she'll just look out and say, okay, I'm all done. And go in there. Oh, thank you so much. Grab the nice folded towels. You turn around. As soon as she stops looking at you, you mess them up again. And then you say, could you help us out some more? And you put them down. Correct. Keep them busy. Keep them busy. All right, let's see what else we have here. This symbolizes scheduled toileting. And we talked about it a little bit before, but if we can get to that patient, anticipate their needs before they have to go to the bathroom, not only is it keeping them on a schedule, but it's preventing it from being an emergency. Because if it's an emergency, Effie's going to want to get to that bathroom super fast, and we might ignore some safety protocol in getting there in time before she has an accident. So scheduled toileting is huge. If it's every 2 hours, every 3 hours, communicating that to the nurse assistant and the RN, creating a team to make sure that happens is going to prevent falls. Right here, we've got the fall risk wristband. So this has to go on all of our fall risk patients, just so that we know they are fall risk. Some hospitals, you'll notice that they wear yellow non-skid socks. We don't do that here at St. Joe's, just because it seemed like everybody was wearing non-skid socks, or wearing the yellow non-skid socks. Managers were starting to come in with them on, so we decided to pull that and just use this as their visual indicator. The other thing is the dome lights outside of their room, our nurse call system, they'll have 2 yellow lights showing that they are fall risk. What else? We're talking about socks. Let's go ahead and get right into them. So these are non-skid socks. So these are going to prevent falls. If the patient, they don't like these socks for whatever reason, They can use their own shoes, just as long as it's non-slipping. They can use them. I don't know why you would want to use it. Beautiful shade of green. All right. How does this prevent falls? What is this? Yep, you got it. It's a gate belt. So any fall risk patient, for getting them up, we need to put the gate belt on them. And we're going to tie it right to the footboard so it's easily accessible. It just takes a second to put them on. But that's another thing. We don't want it to be an emergency. So we want to have that extra 20 seconds to get this on the patient to keep them safe. Gives the patient handles so it's easier to control them once they're up and moving. Another thing is once here. Handle. Here we go. So a call light pillow speaker. So this just symbolizes making sure we have everything they need right by the patient. So I want this on the bed where they can easily grab it. I also want to make sure their cell phone is nearby, their Sudoku book, whatever it may be, is right there with them. The telephone for the room, I want it right there so they're not reaching for it. So many falls are, I was in the chair, I left my cell phone on the other side of the chair, I had to get to it for whatever reason, and they fall. So every time I leave the room, I always turn back around and do a snapshot. They have everything that they need right in reach. Let's see. Duplicates. This symbolizes purposeful rounding. Used to be hourly purposeful rounding, so that's why I use the stopwatch. But yeah, again, if we can plan out and anticipate those needs before they happen, we're saving ourselves tons of time and we're keeping that patient safer. So purposeful rounding. Of this, how does that show? How does that prevent falls? Prescription glasses, and we'll pretend like hearing aids as well. If patient needs glasses or hearing aids, we need to have them on when we're getting them up to the bathroom, when they're getting anywhere in the room, if they're doing therapy. And if you think that patient is now weak because they've been in the hospital for a couple of days, you need to get them up somewhere. And also they can't see very well and they can't hear your direction. It's gonna be tough. They might fall. So make sure you have all these things set up so it's fit for activity. About this, how does this prevent falls? The Usher's CD he released in 2000. Yeah, distraction, you got it. So again, just like the hand towels that we talked about before, if we can distract that patient, keep them from worrying about getting their cat in the closet or just needing to get up to see somebody. If we can distract them, we're going to keep them safer. Huge. Just think, what other ways can you distract the patient? You know, we've got the TVs here, put on their favorite show. We've got old time movies. We've got these movies. We've got Pandora. So many different ways to keep these patients occupied, distracted. So they're not worried about getting up and doing something and then save the fall. All right, I got a couple more things in here. I know you guys don't want this to end. Blood pressure cuff. Just making sure that we know what their blood pressure is. All fall risk patients should have an orthostatic blood pressure done, so we know if they drop when they get up. Let's see. Got one of my favorites here. It's probably hard to see, but this is a nurse's station. So the way that this prevents falls would be get that patient to a room closer to a nurse's station so there's more eyes on them, so it's quicker for you to get to them if you guys are charting in the nurse's station. That makes me always think about the G tower, G wing. If any of you guys work over there, 2G, 3G, 4G, there's a couple of rooms where we should really try not to have fall risk patients, and that's rooms 19 and 25. They're so far away from everything, you have a lot of eyes on them, and it takes you a while to get to those rooms. So always try to move that patient to a room where we can easily get to. We know what they're doing. Other things here, got this is, I can't see that, but it says family on there. So family support can be huge, especially before COVID. We could always, ask a family member, hey, can somebody come in and stay with your loved one tonight? We don't have a sitter. I'm just worried they might fall because I can't keep my full attention on them because I have other patients. And usually half the time when I work nights, I would get a family member to come in and help out. It's amazing. But we have to educate the family. It's kind of a double-edged sword because sometimes families can cause falls. So I always think about the family that gets annoyed that the alarm keeps going off. And then they see you turning it off. So then they're like, well, I'm going to turn it off. I'll keep the patient safe. Then they leave, forget to tell us that they turned off the alarm, and then the patient falls without the alarm on. It's like, oh, I know I had the alarm on. The other one would be the patient that is also a caregiver. They always get the patient, at home, they get them up to the commode easily. But now that patient's become weaker, they've been, they're sick. They've been in the hospital bed for a couple of days. So now they don't have the same strength to help the family member get them up. So always tell them, let us do it. We're trained specifically to help them when they're weaker. That is about it. Making sure that we're doing education on medication. I know I talked about that in the PowerPoint quite a bit. But yeah, it's thinking outside of the box. How can you keep them safe? How can you distract them? Are there things that the family can bring in from home to keep them distracted? Just so many different things, and that's what I challenge you guys with is what new fall intervention can you put in place to keep that patient safe? All right. Thanks so much. Have a great day.